Delighted to welcome my next guest, Danny Mortimer, who's Chief Executive of the NHS Confederation. Danny, there are so many different NHS bodies. NHS Confederation, of course, representing NHS Trust, is that right?
Good morning, Julia. We represent all types of NHS organisations across England, Wales and Northern Ireland, so trusts, primary care networks and various other organisations that also are paid to provide NHS services.
OK, right. Now, let's talk about where we are. We're told that, we know deaths are now at 83,203, up 1,243 reported positive COVID tests of deaths in the last 24 hours. We're also told that there are 35,000 people in hospital who have tested positive for COVID and more than 3,300 in ICU receiving specialist intensive care. The hospitals are massively under pressure now. There's no doubt at all about that. Some hospitals in some areas are saying they're close to being overwhelmed. But reports today suggesting that we could be seeing pressure on the NHS not easing until March. Tell us why that is.
So there's a few things there, Julia. I think it's fair to say that every part of the NHS is under pressure at the moment. You're right that there are some variations around the country. We've rehearsed particularly the impact that we've seen in London and the South East over the Christmas New Year periods. But that in some ways was just a few days or a week ahead of most other parts of the United Kingdom. The pressure is being felt in hospitals, as you said. It's being felt in ambulance services at the moment. Huge disruption to ambulances, dropping off patients at hospital, massive waits there for them, greater delays than any of us would want to see for people when they call an ambulance to come and attend them. A lot of people with coronavirus are in the community, of course, not in hospitals, and that's impacting on our colleagues that provide services there.
Okay.
And what we see, of course, is that as rates of infections grow, the demand for care grows. The harm that is being done to people's health grows, and it's going to take some time for that, the effect of the lockdown to be felt, and for us to turn that tide of infections, and for us to reduce the harm that's being done to our friends and our neighbours.
Okay. Now, going back, you said London Ambulance Service. Facing with some areas. Some hospitals are they're at high levels of patients and care because, of course, it's winter, and that was always the case. A number of NHS, and not just one who said this to me, but a number of NHS chief executives of hospitals said to me, look, we do have, an NHS crisis every winter. That is something that we really need to tackle. This is not the norm in most other countries, having a crisis every winter. There is clearly a funding issue. There's a staffing issue. There's lots more going on, and we need to tackle that once and for all. I think once this crisis is over. But we know that ambulances, that they're under pressure. People are waiting a long time for an ambulance because the ambulances have got a patient in them and they can't drop off at an emergency unit because there's this issue about testing patients and about separating patients who might be COVID positive, might not be COVID positive, and the people who tested negative. That separation, that has caused a lot of the problems. There's also an issue, isn't there, in terms of staffing? Huge numbers of staff. Is it right? It's something like up to 30% in some hospitals who are either off sick with COVID, or in most cases they are simply self-isolating with because they've been in contact with someone who has tested positive for COVID. Is that one of the biggest issues? If we could resolve the staffing issue, would things be better?
So, really important points that you raised there, Julia. You are right. The failure to properly invest in the NHS over many, many years now, over probably 15 years or more, creates that pressure every winter. The fact that we unfortunately have seen disinvestment in social care over the same period also exacerbates those problems, because of course many people who attend hospitals in winter then need to be able to move into areas where they get support with their care, whether that's in their own home or a care home. And we've not addressed that question as a nation now for a very, very long time, and that creates real problems. The issues around the ambulance service, yes, it is more complicated to admit patients now because of the virus. That's true, but it's also the case that lots of hospitals, frankly, are just full, and what we need to be able to do is move patients into the emergency department and then through the emergency department into our beds, and then many people obviously end up in critical care beds or in beds where they're receiving help with their ventilation. And whilst the NHS has massively grown those beds, in many parts of the country now there are 50, 75%, even 100% more critical care or assisted breathing beds than we had 6 months ago. There's that enormous pressure and backlog. Okay. Staffing is a key issue. We are, we had real staffing challenges before the pandemic. Again, speaks to that failure that you described in terms of underinvestment over many, many years. What we are seeing is that there are, our staff are no more immune from the virus. Their family members are no more immune from the virus, sadly, than anyone else. And we are seeing much higher levels of sickness absence. You would at this time of year, obviously, lots of bugs going around. We see higher absence in the NHS anyway, but it is much, much higher. Some people are reporting that it can be as much as twice as high as they would normally experience in a December or
But some of it
January.
is not people being ill themselves. And of course, there are some jobs which you could do where if you did suspect not with COVID, but in a normal year, you might suspect you had a nasty cold. People might still go into the office, or probably lots of places would still be forced to go in. But in times of COVID, obviously, any hint of any illness, people are absolutely encouraged to stay at home, and quite rightly. But a lot of this is people who are self-isolating. Now, there's been an issue about handing out lateral flow tests to staff to try and rapid lateral flow tests to get them so they can test themselves. Big concerns about how they miss, particularly if people are asymptomatic, how they actually can miss more than 50% of those positive cases. How reliable are they? Are you using those in the NHS or not?
So I'm not a scientist, Julia. So I'm probably not able to go into the science of the tests. But yes, they are being used. But of course you're right. The higher rates of absence at the moment are a consequence of the impact of the virus directly on people's health. But they're also
that was bureaucratic speak. So do we know roughly what the percentage is of each?
Forgive me, I don't immediately have to hand the percentage of people who are COVID positive and ill because they have coronavirus, and the number of people who are having to isolate.
I don't expect you to have every figure. No. I just like to have a rough idea, because those things are two different things, obviously. And if there's one that we can resolve more easily, which is people self-isolating, then that would be something we should perhaps pressure to resolve. One of the things I think a lot of people are concerned about at the moment is whatever people's views are on whether there should be a lockdown or not, and I'm certainly opposed to lockdowns, even in winter crisis times, for many different reasons in terms of long-term effects and the like. But whatever those people's views are, we know that every winter we have extra pressure. We know that, and we know that we now have a seasonal, as Patrick Vallance predicted in March, we now have a seasonal endemic virus for which we do not have a vaccine in the same way we do for flu. We're rolling out that vaccine. It's a wonderful miracle that's been done. All credit to everybody involved in all of those vaccines, and indeed in the rollout. And it's an amazing achievement by humankind. But given that the NHS and the government indeed have been talking for months about how, we're going to face pressure in the winter, it's going to be like never before when we see a second wave. The talk of this second wave has been, going on for months and months and months. Why then were the Nightingale hospitals effectively mothballed? Why were hospital staff allowed to take their booked holidays in over the Christmas period? Why were more beds not brought in? Why were not the staffing issues allayed in some part by bringing in an awful lot of the volunteers, retired medics? I know an awful lot of people who happily volunteered back in March to sign up to be volunteers to return. Well-trained people, retired in recent years, really able to do their bit. They've emailed, they've called, they've done it. No one wants them to work. No one's calling for them. Why did the NHS do so little to prepare for a crisis which they themselves predicted would happen?
An enormous amount of preparation has been done and is being, and an enormous amount of response is happening at the moment, Julia. There is extra capacity being opened almost daily in the NHS. You will see, as I said, areas across hospitals now being converted into places where we can assist patients with their breathing, critical care beds in particular. One of the reasons we're disrupting, unfortunately, so much other care is because we're taking places like day surgery units and turning them into critical care beds. We're creating huge extra capacity. 50, 70%, 100% even extra capacity in many places to do that. We're looking at how we can, because of the pressures on our colleagues in social care, how we can move people into other places, hotels even, where they can get support with their care whilst they're away, so they can get fit enough to get back into their own homes. And that concentration of staffing resource. My members run the hospitals and provide the services. They don't run the NHS nationally. That concentration of staff and resources in their own institutions, running those extra beds, and they had these what are called surge plans. They had these plans ready, and they are deploying them. But deploying those beds does stretch the staffing resource far more thinly. It does create that pressure that we've talked about. And of course, every time we have to open those surge beds, it's a sign of the number of really sick people that are being admitted to hospital. It's a sign of the harm that is being done to people of all ages right now, and potentially for the longer term as well, in terms of their long COVID.
But can I clarify though? Can I clarify, Danny? I mean, you're not a medic and I'm not a medic, but the statistics are actually the vast majority of people, as was stated by Chris Whitty back in March and Patrick Vallance, the vast majority of people who do get COVID will not have any serious illness and will not have any serious long-term effects. And in fact, a huge percentage won't even be aware that they've even had the virus because the symptoms will be so mild. I mean, we know that there are people who are younger, who are otherwise healthy, who are long-term affected, and some of those people sadly will die. But the vast majority, it is the case statistically, the vast majority of people will not have any of those effects.
But those people who do become seriously ill with the virus, the evidence that's growing over this last 9 or 10 months is that actually for many of them, except it's not all of them, Julia, but for many of them, there are long-term consequences. There are people who had COVID back in the spring who still haven't fully recovered from that experience. There are people who are reporting, and their clinicians are reporting, apparent signs of long-term damage to their internal organs, to not just their lungs, but also heart, kidney, spinal cord, even in terms of the consequence of the virus.
Again, I'm not in any way minimising that for those people, but again, we need to stress, do we not, because we deal with facts on this show, we need to stress that is people who have had very serious, been hospitalised, been seriously ill with COVID-19, which is again a very, very small minority of those who do get COVID. We need to keep this in perspective, do we not? And that's not to minimise it. It's not to say it's not a dangerous disease, but we need to keep that in perspective.
We do absolutely need to keep it in perspective, and of course. There are many people who, as politicians and Professor Whitty have talked about this week, are COVID positive and don't realise they're COVID positive and can pass the virus on to their, unintentionally to their loved ones. But the fact is that actually, again, keeping it in perspective, this virus, which at its peak back in the spring, saw us admitting 17 patients per thousand patients, to ICU, compared to what we would normally see in a flu season, 3-4 times higher than what we would normally see. Where people do contract serious symptoms, it is much more serious for them. It's much more demanding of the NHS in terms of the care it's providing. And for a significant number of those people, there are those longer term consequences that you and I have talked about.
Danny Mortimer, thank you so much for talking to us. I think that was really helpful for a lot of people to listen to what you had to say there, giving us the picture of what is really going on in the NHS. Chief Executive of the NHS Confederation, Danny Mortimer.